this learning module, we're going to be talking about how to define pain and what is the balance in pain management in the setting of prescription drug abuse. First, the definition of pain. There's several definitions of pain. The one we're using is quoted from the International Association for the Study of Pain. And pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Now, most of the medications that we consider pain medications, analgesics, we are aiming for that sensory part of pain. Where the difficulty becomes is when the patient is using these analgesics, and specifically opioids, to address the emotional experience of pain, which becomes really important in the chronic pain situation. Now, since 1999, the American Pain Society has mandated that all healthcare staff record pain assessment each time other vital signs are recorded. So, for example, when you go in and see your primary care physician, before the visit, all your vital signs are recorded and you're asked to record or rate your pain from 0 to 10. Now, whether it's coincidence or whether because we've done a good job of assessing pain and maybe prescribing meds, we now have shifted the pendulum and there's some concerns with specifically the opioids. So between 1996 and 2006, the number of overdose deaths from opioids have tripled. 17% of these deaths have involved a combination of opioids and other sedative medications like benzodiazepines. And the opioid that has been involved with the most overdoses is methadone. A newer analysis has shown that opioids were involved in 68% of overdoses treated in the emergency department. So more than half of the overdoses were related to the opioids. And as you can imagine, this drives up the cost of healthcare. Now, a recent update has shown in 2014 that opioid or deaths related to opioid use and misuse has dropped the first time since 1999. But unfortunately, with this drop of opioids, there's been an increase in heroin use and deaths. So we find ourselves in an unbalanced pain management setting. We could either underprescribe opioids with the risk of the patient suffering from continued pain and the risk of this pain getting worse, and we'll talk about this later. Or we can overprescribe opioids with the risk of patient misusing or abusing opioids. So you ask yourself, how do you find the balance? How do you prescribe just the right amount of opioids without the patient suffering or misusing? Well, as a pharmacist, regardless of what setting you're at, you ask yourself the following questions. Are opioids first line or indicated for this type of pain? And if not, what's a better medication for this type of pain? And if we're going to use opioids, can we set limits on the opioid use so that it doesn't get out of control? Can we recommend to the provider to prescribe a limited quantity? Let's see how the patient does with a set dose for a set time period, and then let's monitor the patient frequently. Can we recommend this frequent monitoring? Can we reduce the dose of opioid? And by recommending something else. And this is usually called opioid sparing. And you can recommend non-pharmacological approaches, adjuvant, and in this case, we're talking about non-opioids and preferably non-controlled medications that can be added on to the opioid regimen to help decrease the amount of opioids used, but also help with the pain. The symptoms of neuropathic pain and its treatments. So neuropathic pain can derive from either peripheral or central damage to the nervous system, and the patient will describe this type of pain as either burning, shooting, pricking, or numbness type pain. Under normal conditions, there's a balance between excitatory and inhibitory neurotransmitters. Changes to this balance, either peripherally or centrally sensitization, can lead to exaggerated responses, such as allodynia, which we've talked about, which is pain to non-noxious stimuli or light touch, or hyperalgesia, exaggerated response to noxious stimuli. So a mild noxious stimuli but causes very severe pain. So the treatment of neuropathic pain based on several guidelines is based on efficacy and tolerability of the medication. And so this quadrant, which is the most efficacious and the most tolerable, are your preferred first-line agents. So it can either include gabapentin, pregabalin, your TCAs, and in this case I've listed amitriptyline and disipramine, and your serotonin norepinephrine reuptake inhibitors. The most common ones that are used in this class are duloxetine and venlafaxine for neuropathic pain. Now, although lidocaine patch is just a topical agent, it's probably not as effective as the first three agents, but it is very tolerable and it does fit into the category of first-line agents. So again, as a review, your first-line agents, your TCAs, your SNRIs, your gabapentin, pregabalin, and then your topical lidocaine. Your second-line agents, which is oxycodone, morphine, methadone, and tramadol. So the opioids, or anything that hits the opioid receptor. These are second line for general neuropathic pain. Now, if you're talking about neuropathic pain in the cancer setting, these can be bumped up, especially methadone, to first line. And then last line, or refractory neuropathic pain, includes agents such as ketamine, cannabinoids, botulism, and capsaicin. And you can also use intravenous lidocaine in this setting as well for refractory last line neuropathy.